me this opportunity. B-scan ultrasonography is a very useful non-invasive imaging technique in the detection of tumors in eyes with opaque media, for characterization of tumors in eyes with clear media, and finally to differentiate tumors from mimicking conditions. But before ultrasound can be used, there has to be certain prerequisites. The lesion that we are going to image should have a minimum elevation of at least 0.8 millimeters from the surrounding retinochoroidal layer, so that we can precisely detect it, because a very flat lesion, it's very difficult to characterize the features. But for further characterize it, ideally it should have an elevation of 2 to 2.5 millimeters. But all these will depend on the location as well as the internal reflectivity. For example, if we are dealing with ciliary body tumors, the lesions has to be much larger, and in these situations either one can use the immersion technique or one can use for probes with a higher frequency. And another option is to go for UBM. So like we follow the standard techniques, especially when we are evaluating any patient suspect to have an intraocular tumor. First we do a topographic evaluation, which will help us to know the exact location of the lesion, the shape, the surface, as well as the extent of the lesion. Then we do a quantitative evaluation, where you get an idea about the reflectivity of the lesion, the internal structure, which is decided by the histological details, and finally whether it is causing any sound attenuation. And then we do a kinetic evaluation, where the probe is held steady and any flickering movements on the A scan will indicate the vascularity of the lesion. And all these findings are taken together to come to the final diagnosis. These are some of the tumors where ultrasound is very useful. All these tumors has characteristic clinical as well as echographic findings, but we come across with atypical findings very often, and most often we have to combine the clinical as well as the ultrasonographic features to come to the final diagnosis. One of the most important uses of ocular echography is in the evaluation of choroidal melanoma, which is the most common intraocular tumor. Characteristically, it is seen as a solid dome-shaped lesion or a mushroom-shaped lesion, which is also known as a collar button lesion. And this collar button shape indicates that the tumor, which arises from the choroid, has broken through the RPE and comes to the subretinal space. And this is one very characteristic feature of melanoma. The surface of the lesion usually shows a high reflectivity, but the intralesional occurs show progressive decrease from moderate to low reflectivity towards the base of the lesion, and this decrease in the reflectivity that we see on the A scan is known as angle kappa, and on the B scan the low reflectivity towards the base of the lesion is known as acoustic hollowing. Sometimes in large tumors there can be significant attenuation of the orbital echoes also, which is known as a orbital shadowing, and the normal highly reflective choroid, when it is replaced by the low reflective tumor, then we call it as choroidal excavation. These features are so characteristic of melanoma that the accuracy on ultrasound is more than 95%. Sometimes we do see unusual features when evaluating melanomas. Large tumors can sometimes show areas of variable reflectivity or cystic changes which indicate hemorrhage or necrosis. Dr. Nitin was already saying that any case of unexplained vitreous hemorrhage, we should carefully do an ultrasound because there could be a hidden tumor beneath it. Sometimes there can be features of inflammation like thickening of the sclera, which can be because of the inflammation induced by the tumor. Very rarely one may see calcification on the surface of the lesion, and it's also important to remember that sometimes melanomas can present as a diffusely infiltrating tumor without a typical mass lesion. Ultrasound is of course extremely useful to get the accurate dimensions of the tumor. We have to measure the base of the tumor as well as the height of the tumor, and these measurements help us to monitor the tumor for its growth or regression during serial examination. It helps us to know whether the tumor has grown beyond the ocular structures and has caused any extrascleral extension or any orbital involvement. It helps us to decide the exact size of the plaque if we are planning any brachytherapy, and following treatment these lesions show varied reflectivity and the height of the lesion also decreases, and thus it also helps us to know the effectiveness of treatment. Though it is little more difficult to evaluate the lesions of the ciliary body or the iris, and nowadays UBM being more widely used, the ultrasound is still useful to differentiate these solid lesions from cystic lesions or from detachment of the ciliary body. Moreover, it also helps us to know whether a ciliary body melanoma has progressed to involve the choroid. Definitely, ultrasound is useful to differentiate the other tumors. One such condition that we commonly come across is a circumscribed type of choroidal hemangioma, which, similar to melanoma, can be posteriorly located, is a solid lesion with a dome-shaped surface. But unlike a melanoma, hemangioma usually causes high internal reflectivity, and it usually does not cause vascularity. So these two features, which often helps us to differentiate hemangiomas from melanomas, and usually the retinal detachment that we see in hemangiomas is more extensive than what we see with melanomas. But also remember that sometimes we do see the diffuse type of hemangioma in association with Sturge-Weber syndrome, where we may not see a typical mass lesion, but it can be just a thickening of the retinochoroidal layer, which is more obvious on the posterior pole, and in doubtful cases it is always better to compare the thickness between the two eyes. Yet another lesion which can be confused with melanoma, especially the amelanotic variety, is a metastasis, and we all know that choroid is the most important ocular structure that is involved by the secondaries. These metastatic lesions can be unilateral or bilateral, can involve the posterior fundus, sometimes more peripherally also. It can be focal, multifocal. Usually it's not so elevated, and here is again one important difference between melanoma. Like the thumb rule is, in melanoma the height of the lesion is usually more than the base of the lesion, whereas in metastasis it is usually the base of the lesion which is more than the height of the lesion. Another characteristic feature of metastasis is the typical lobulated appearance with irregular internal structure and usually medium to high reflectivity. Again, the retinal detachment that we see is much more extensive than what we see with other tumors. Metastasis again can have all kinds of atypical findings. It can be associated with vitreous or subretinal hemorrhage. There can be associated choroidal detachment apart from the retinal detachment, and ultrasound will also help us to know whether there is involvement of the orbit as well. As I said earlier, exceptions are the rule here also. Like any secondaries in the eye from a primary melanoma elsewhere will show all the features of melanoma, and similarly metastatic oat cell carcinoma always causes a lower reflectivity. Another tumor which, though rare, we do come across is a choroidal osteoma. Clinically you see it as an orangish plaque-like lesion along the posterior pole, and it might be confused with an amelanotic melanoma, but ultrasound is extremely useful because the presence of the bone within the tumor shows extreme high reflectivity with complete attenuation of the scleral and the orbital echoes, and this high reflectivity persists even at low gain settings. We know that sometimes we do confuse these tumors with lot of simulating lesions. We have already seen few cases of hemorrhagic choroidal detachment which can present like a mass lesion, but the associated clinical findings and the follow-up during which the size of the lesion changes, the reflectivity changes, and the mobility will help us to diagnose this condition. A dislocated lens, especially when it is fixed to the posterior pole, can be confused with the tumor, but the associated clinical findings will help us to diagnose, and moreover we can see that with the eye movement the lesion also changes its location. Nodular type of posterior scleritis can again present with a mass lesion, but here the associated features of inflammation such as thickening of the sclera and widening of the tenon space help us to differentiate this entity. Ultrasound in general is very useful for the evaluation of opaque media in children, and it is especially useful in the evaluation of retinoblastoma, where it helps us to confirm the diagnosis. It helps us to look for small peripheral tumors which can be easily missed on clinical examination, and it is again useful for follow-up after the treatment. The most important feature in retinoblastoma that we look for when you are doing echography is the presence of calcium, because the diagnosis is based on the display of calcium. It does not depend on the histological nature of the tumor or whether the tumor is endophytic or exophytic. If we are able to demonstrate calcium in a mass lesion in a child less than 3 years, you are almost sure that you are dealing with retinoblastoma, but sometimes even lesions without calcification can also occur. In some situations where if the dense calcification causes significant shadowing, one might have to go for CT scan, especially to know the exact posterior extent and to know the optic nerve invasion. Like some of the other conditions which can present with leukocoria can be definitely distinguished based on ultrasound, like PHPV, ROP and Coats disease. It has already been covered. PHPV typically shows a band, ROP shows the RD closed funnel with peripheral loops, and Coats disease also shows RD with subretinal echoes, but characteristically none of these lesions shows any mass lesion. Rare inflammatory causes and tumors like astrocytoma and medullopathioma tumor can also present with leukocoria, but echography is very useful to distinguish these entities. To conclude, B-scan ultrasonography is very useful in the diagnosis and differentiation of tumors, to know the exact location and its spread beyond the ocular tissues, further measurements which are important to follow up, and to know the effectiveness of treatment. Thank you.